Okay, see, already down one already.
So look at that, Jeff. That's a lot.
I know. I didn't think I was that conflicted, but anyway.
I mean, it was on everybody's mind.
We're going to call them.
Maybe I'm more honest. Maybe I'm more honest.
We're going to call them disclosures, not conflicts.
Yeah, exactly. So there they are again. So this is going to be a problem we haven't solved yet, and I'm anxious to hear what the panel thinks and give us the right answer at the end, because I certainly don't have the right answer for this. We're not a transplant center, but we're affiliated with one, and so we do VADs, and we have a VAD, very, very active VAD program. And I think the HeartMate 2 data for destination therapy is pretty impressive, 46% rates of survival with no disabling stroke in patients who get the HeartMate 2, and 11% in those who don't. So it is actually a life-saving device, probably as good as TAVR. The problem is that because the continuous jet of the LVAD on the aortic valve, that patients do, in some cases, develop a severe aortic insufficiency, and people try to figure out actually how you can actually fix that and prevent the flow of blood as a continuous aortic regurgitation from the aorta back into the left ventricle that causes demise. So let me tell you the case. So 72-year-old man, end-stage ischemic cardiomyopathy, had a HeartMate 2 implant, worsening AI, came in the hospital because he had failure to thrive, low cardiac outputs, and most of the problem was that he had continuous aortic regurgitation at the end. Now, in town in Boston, we tried some balloon expandables. They had embolization into the ventricle against early stages of this, and that was a problem, and you could see exactly why that would happen, because once the valve's deployed, the continuous force is to push the valve back into the ventricle. That may change now with S3, but at least with the early XT devices. You can see the real challenge if you're a CoreValve implanter about what the challenge is here, because there's actually no calcium. So it's a big valve, no calcium, and most of the force from the left ventricular assist device is from the aortic into the ventricle that's constant. So we decided we were going to try to do CoreValve in this. The annular diameter was 26.4, had a very large SOV. So then at that time, all we really had was a 31 millimeter CoreValve. I'll show you how we set up this particular case, and you see the continuous aortic regurgitation in the dilated ventricle from this coplanar view. And a couple technical notes is that we had pretty extensive 31 millimeter CoreValve experience by that time. So we knew, at least in our program, what our fundamentals were. And the fundamentals were you use a Lundquist wire, you push forward on the Lundquist wire, you stabilize the CoreValve device, you do a very, very slow, painfully slow retraction of the sheath to keep everything in place. And so this is where we started. And you'll see on the left screen that we're about 4 millimeters or so deep. Things look good. On the right screen, you'll see that the 31 millimeter is a big valve, and it really expands across at an angle. The 34XL doesn't have that angle now, but the 31 certainly did. But we thought we were in reasonable position, and we were happy with this depth and the amount of regurgitation. But the problem was that even retracting the Lundquist wire and pulling back the nose cone centrally, in retracting that stuff, we popped up into the aorta. Now, the second thing that we've learned from this is that the sinus valsalva width was large, but it wasn't unable to have a tube graft. So we knew we had to pull back the valve, so we did. I got a snare, retracted this back into the ascending aorta, advanced in another 31 millimeter CoreValve. Again, this time we were a little bit smarter, we thought, so we were going to do some fast pacing. We actually cut down the flows on the LVAD device during deployment. We thought we were in good position again, but during the deployment, it popped before we got out there. So now we're lodged in. I'm just showing you what happened, okay? I'm seeing some faces up. So what were you thinking? So now it's worse, because now the 31 millimeter has locked into the first CoreValve, and we can't get it out, so we had to deploy it there. So now we've got 2 CoreValves in the ascending aorta, but we think we had figured it all out by that time. And we thought we'd go for a third one, because Medtronic doesn't charge unless you use 3. Unless you use more than 3. And we actually put the next one down, which we thought was a near perfect implantation. But I'll show you what happens with this one. So we release now. Yeah, I hope it'll show up okay. Because what you'll see is even after a release at a perfect implantation depth, what happens over the next 4 or 5 cardiac cycles, there's a migration of the valve into the left ventricle, right? So we had perfect deployment. We were done. We were high-fiving. And as we were watching ourselves now, we actually went down. Now we were pretty fatigued at this point in time, and the patient actually collapsed, CPR, and went into complete demise at that point with no blood pressure. So we instituted a fem-fem bypass. This aortogram shows what the problem was. Any thoughts about next solution? Maybe a fourth CoreValve? No. We went in with a Sapien, and we decided now we've at least got something that's metal in the left ventricular outflow tract. We can do this. But again, the forces during the deployment forced us down into the ventricle. And to make a long story short, we put a second 29-millimeter Sapien 3 in, dilated it big. And then at the end of that, we actually had a pulse and a blood pressure, and we thought it was time to get out of Dodge with that. Now, as it turns out, surprisingly, with the 5 valves that this patient has in right now, the patient did remarkably well. I'll show you CT in just a second here. And it kind of shows the physiology. So you'll see all of our core valves in our Sapien, but the right screen is important because this is a dynamic CT, and what's not opening? The aortic valve's not opening. So that's the whole purpose for having the valve there in the first place, is that it just doesn't open. So we certainly learned a lot from that. We searched the literature, so maybe we should put a septal occluder in instead. But you'll see where the septal occluder is in this particular case report. It's down at the inflow cannula, so that doesn't seem right. We looked at the work that Chad Hughes and Kevin Harrison had done with surgery, and you get Mike's comments about this, but now we actually encourage the surgeons to either do a valve replacement at the time of the VAD implantation, which is probably the best thing to do, or to actually ligate the valve itself. So it's a quick case. It's probably our toughest case that we've had with CoreValve. We learned a lot with it. The new technology requires innovative solutions. We haven't figured out how to handle the AI with VADs right now. We certainly tried a lot of things. Maybe the solution is going to be a 34XL that's retrievable, but as you saw, once we had the 31 in perfect position, we still had migration into the left ventricle because of the absence of calcium. Maybe an alternative device like a cementless device may be better, that will actually capture the leaflet itself. And I'm not really sure that implant closure devices are going to be the best. So let me stop there, and thanks for your attention.
Do you think there's any potential for pre-stenting? You'd have to probably be on bypass, but to, as our pediatric colleagues often do, put a bare metal stent.
It's a great idea. I think that's probably one that.
Is that it opens up the AI more. You can put a continuous loop.
During
No forward output at that point.
Yeah,
Right.
and even though there's no support
you have
device
to
that'll
have
help
some
with that,
kind
right?
of additional bypass, and then I guess venting.
For AI, it's.
We've thought about that. I mean, it just creates, even if you put it on an ECMO, you're just going to blow up your ventricle. It's a real problem.
Do you have any other? What do you guys do?
Well, we did it with the CoreValve. It's tough, and we turn the flow down because you can't rapidly pace these people because it's the pump, not the heart. I think the cementless valve is good because it's going to rest on top of the valve. But even that may not be in place. We go in and sew the valve up a lot.
Yeah. Sushil, what do you guys do?
The same thing. I think we've done one case like this. But it was a patient that had some calcium in the ascending aorta, so I think that allowed the crown to at least anchor in the ascending aorta.
Yeah.
But I don't think there's any of these are viable solutions, though.
Paul, you have a comment?
Yeah, so we had a case very similar to this, and we actually talked Medtronic into giving us a valve in which we actually cut the leaflets out to sort of pre-stent, and it still got sucked into the LV. So 2 valves. So very, very similar scenario. So
Yeah. All right, good. Well, somebody's got a solution, then email it to me. Good. Thanks. Yep.
We actually had a very similar case with the LVAD patient with severe AI. We did use a cribriform septal occluder with very, very good result. But we used CT for sizing.
Yeah.
And I think there's a paper out of Chicago where they did 5 cases, and they all went well.
With oversizing and not being sucked into the LVAD.
Yeah, and it was stable, and AI essentially disappeared. And if you look at the echo, the aortic valve was not opening at all, so there's no reason to maintain flow through the aortic valve because there isn't flow.